Dear ROECSG and esteemed audience, thanks a lot for allowing me to introduce the clinical oncology module. My name is Yannick. I'm a radiation oncologist and GP, but mostly work in education at present and have been auditing residency programs since when I started as an attending physician in 2017. As of time constraints, I would urge you to watch my presentation on the ESTRO core curriculum or CC of last year's spring symposium, as to I will be referring to it here. So this CO or clinical oncology module is designed to be seen in conjunction with the mentioned CC 4th edition. Concerning its provenance, I would shortly like to highlight how the CC came to be a minimum curriculum, which is different and more flexible than maximum curricula like from ESMO or ASCO, so it is based on law and guidelines following the zeitgeist of competency-based medical education and finally arriving at EPAs. Here we go. The CO, on the other hand, focuses more on the medical expert role in addition to the CC, within which it adds another 20 EPAs, but we will shortly come to that. Also, the workgroup faced some COVID-related interruptions, but as you all know how to sing along that one, there's no need to introduce more cats and jammer here, I'd say. But before that, what actually is clinical oncology? A European questionnaire discovered nations have different residency curricula. Firstly, for our non-surgical oncologists, calling themselves clinical or simply oncologists like in Scandinavia. We even do nuclear medicine in addition. Secondly, training medical and clinical oncologists like in the UK. And thirdly, training medical and radiation oncologists like in the German-speaking countries who may or may not prescribe systemic therapy. And that's hectic for standardization purposes, of course. So like during the work on the CC, we aim to increase international utility and feasibility for the CO, and additionally included colleagues from low and middle income countries in and outside of Europe, which was actually Albania and Senegal. What resulted from this work is a single, complete minimum CO residency curriculum. As you can see, we in general propose the same required EPA levels for systemic anti-cancer therapy as for radiation therapy from the CC specifics, and introduced cancers not requiring radiation, but hereby excluding lymphoma, as you can see. Other examples for the CO EPAs will be to focus on symptom control, supportive care, and palliative medicine, when further or even neither radiation nor SACT is appropriate, and communicate this rationale clearly. We also included more general recommendations for training as to program directors, experience of specialist staff, and teaching with feedback. But to talk about the latter, feedback has the potential to fit a complete symposium in and out of itself, I would say. So let's leave that out. Regarding my elaboration on EPAs during my talk last year, please allow me to close with a few dramatic hiccups and cues on the gap between competency or outcomes-based education and EPAs. The good thing is to bring training back to standards, but this may inter alia overcomplicate it to checking catalogs or lists as well. EPAs can break this curse, as to it both increases transparency of learning outcomes and formalizes entrustment decisions, but they indeed implicate major change to benefit patient safety. So as a Europeanized American, actually, I intend to play devil's advocate, again urge you to adopt the work again for ROECSG activities and change over to EPAs if you can. If you want to hear more, please attend my talk at this year's International Association for Medical Education, so AMI, where I will go into more detail. Anyway, what's left to say is, ROECSG, please keep up the good work, and well, 2000 years ago, the proudest boast was Civis Romanus sum. Today, in the world of free global movement, the proudest boast is Ich bin ein ROECSGian.